Hello everyone, my name is Dr. Ashok Kumar. The aim of my lecture series is to prepare you for the USMLE and any other medical examinations through my PowerPoint presentations on different topics and practice questions. So let's go ahead with the today's topic. Let's talk and understand. So, today we are going to talk about acute respiratory distress syndrome. So, as you can see, the name says acute respiratory distress syndrome. So, we are going to talk about the acute condition that is about the respiratory distress. A patient is suffering from respiratory insufficiency acutely in which both the lungs are damaged. So, let's go ahead. Okay, well, so let's understand what ARDS or acute respiratory distress syndrome is. After briefly understanding that, we are going to have a look on the patient's case scenario, how a patient presents with ARDS, and then further we will elaborately understand its pathogenesis and important key points which are to be asked in the examinations, right? All right, let's go ahead. So, ARDS or acute respiratory distress syndrome is a life-threatening respiratory failure due to bilateral diffuse alveolar damage. So it is an acute respiratory failure in which bilateral, both the lungs are damaged on what level? Alveolar level, right? So both lungs alveoli are damaged. So here you can see patient is under serious condition and both the lungs we can see here lung fields have white patches which are infiltrates of exudative edema and cell debris on alveolar level on both lungs. So alveoli are damaged, patient is unable to breathe or severely dyspneic. So furthermore, this alveolar damage, as we understand, ARDS is an acute condition. So that acute means within a window period of 7 days, occurring within 1 week of local lungs damage by pneumonia. So there can be acute lung damage on both sides. So both lungs are damaged due to pneumonia, lungs are damaged, or due to systemic inflammation. For example, sepsis. Sepsis is an inflammatory acute condition that is a systemic inflammation, right? That involves various organs, but particularly we are talking about the lungs. So sepsis, acute pancreatitis, traumas, multiple fractures, uremia, ultimately affecting the lungs. So lungs can be damaged due to local infections, damages, or systemic part of the systemic inflammation in which the lungs get damaged, right? So, but within a 1 week, it can be after 1 day, 2 days. So, let's say patient is suffering from acute pancreatitis. So, after suffering from acute pancreatitis, within 1 day, 2 days, or 3 days, maximum 7 days, now patient is suffering from respiratory distress. Now, both lungs alveoli are damaged. So, we say the patient is suffering from ARDS, right? Great. So now let's understand this case about the ARDS. A 68-year-old woman is hospitalized with a systemic bacterial infection secondary to obstructive uropathy. So patient had uropathy and this infection further disseminated and to the system to cause sepsis. Now From uropathy, the bacteria have disseminated throughout the body. She has been a smoker for last 30 years. On the second day of her hospitalization due to sepsis, right? She develops shortness of breath. Now lungs are suffering. And progressive hypoxemia, since lungs cannot do the exchange of the gases. Now hypoxemia is there in patient, which is refractive to mechanical oxygen support. Patient doesn't respond to the oxygen because now both lungs are damaged. Alveoli are damaged, which cannot exchange the gases. On next day, the patient dies, right? The patient now dies. So patient had breathing severe problem and died of severe hypoxia and hypoxemia and hypoxia. The autopsy of her lung tissue shows hyaline membrane formation in her alveoli. So lung alveoli tissue biopsy shows, after death autopsy shows hyaline membrane formation. Hyaline membrane formation, very typical finding about that can be asked in your USMLE exam and other medical exams, because this is specific finding that a patient suffered from ARDS, acute respiratory distress syndrome. Hyaline membrane is nothing but the alveolar damaged cells and alveolar capillary leaked proteins. We will understand further later. So now the question is, which of the following is the most likely cause of her death? So let's see. Is it emphysema? Because the patient had been smoker. So therefore, the answer is given to distract you. The patient might be suffering from emphysema. Is it emphysema? Is it asthma? Is it congestive heart failure? Or it is acute respiratory distress syndrome, since we understood clearly that patient had severe respiratory insufficiency, severe dyspnea within a 1 week period, window period of sepsis, systemic illness in this case. And the patient had hyaline membrane formation on histopathological level. So it is clear cut the patient is suffering from ARDS, acute respiratory distress syndrome, right? Why we didn't go for emphysema? Because emphysema is a chronic obstructive pulmonary disease of longer duration, chronic disease. And patient slowly develops hypoxia, not to that level to cause death within acute period of time, right? And emphysema actually causes damage to the alveolar walls. But here and in emphysema, there's no hyaline membrane formation. That is actually reserved for D option ARDS, right? So emphysema is excluded. Asthma is also not supportive in this case because asthma itself is an episodic breathlessness, right? Congestive heart failure, if there is a congestive heart failure, again, there should be again progressive history of long running breathlessness, and due to left heart failure, congestive heart failure, there will be engorgement of the blood vessels in the lungs, and there will be actually a transudative fluid accumulation, less protein rich, right? But here in this case, the patient is suffering from hyaline membrane that is protein rich because capillaries are damaged, which are leaking protein rich fluid, right? So in this case, this congestive heart failure also doesn't fit. Actual answer is acute respiratory distress syndrome from clinical history as well as from histopathological finding of hyaline membrane, right? So now the concept is clear. The what we understood, lungs are damaged bilaterally on alveolar level. So alveoli, they are epithelial cells, type 1 alveolar cells and type 2. Type 1 for gaseous exchange, type 2 for surfactant production. Both are damaged, destroyed. And capillaries are also damaged, destroyed, therefore damaged, so ultimately leaking the protein rich fluid and leading to formation of hyaline membrane. So now let's go further understand. So now the concept is clear. So what ARDS is: a life-threatening respiratory failure due to bilateral diffuse alveolar damage. Both lungs alveolar damage occurring within 1 week of local lungs damage. Both lungs are damaged. For example, due to pneumonia, around 40% cases of ARDS suffer from pneumonia. Both lungs are damaged. Now patient is suffering from severe dyspnea, which is not responding to the oxygen therapy because now alveoli are filled with dead cells and protein-rich fluid. Second, other set of patients may present with ARDS due to systemic inflammation that is acute. Systemic inflammation due to sepsis from any other organ, or acute pancreatitis, or traumas, multiple fractures, uremia, and so on. So these conditions or diseases, acute pancreatitis, sepsis, traumas, multiple fractures, brain injuries, traumas, and so on, they actually incite acute inflammation systemically, in which neutrophils get activated, and then they get infiltrated into the lungs to cause bilateral lung alveolar damage. And patient is now suffering from ARDS. Good. So what we understood, ultimately, if the culprit infection started locally within the lungs or systemic inflammation, both conditions are causing activation of the acute inflammation, acute inflammatory cells, the neutrophils. And these are the neutrophils which cause damage to the both lungs alveoli by releasing, proteases, reactive oxygen species, importantly, right? Good. So patient now develops severe dyspnea and progressive hypoxemia, which is refractory to oxygen therapy, right? Alveoli cannot exchange the gases because those are damaged and filled with exudative fluid. So this is on the left side, you see histopathological report, the beautifully looking alveoli. You see these are alveoli. And in between there are capillaries, red cells and other cells, capillaries for gas exchange. But this is a normal person's alveolus. But on the right side, if you see, too many, this purple color dotted nuclei containing cells. What are these? These are nothing but neutrophils, a lot of acute inflammatory cells. And what are these? These are again alveoli, alveolar sacs, alveoli, which are now, you see, instead of here, you see clear, they are clear linings, but here the linings are eosinophilics. What are these? These are nothing but orange color, pinkish color, protein-rich fluid, exudative edema, and the cells which were lining the alveolar cells, which have now died. So this is containing cellular debris of these epithelial cells and the leaked protein, because capillaries and alveoli both have got damaged. So these capillaries have leaked the protein-rich fluid. So protein-rich fluid and the cellular debris, right? That is called, this hallmark is called hyaline membrane. So this is called hyaline membrane, right? That is a hallmark of acute respiratory distress syndrome. Why this happen? Because of the release of proteases and reactive oxygen species from neutrophils. Yes, good. So from the neutrophils. Okay. So now radiology report of this patient will further show what? Bilateral alveolar infiltrates, diffuse alveolar infiltrates in both lungs. You can see white, 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 white spots. These are actually the edema and cellular debris within the alveoli. in both lungs fields, right? Okay, good. So now let's move further. Causes, already we understood briefly again. Patient's history, if you see a case scenario in the exam, you will see what? Patient's history or case scenario will suggest that he or she suffered severe dyspnea within a week of any of the following. It can be local lung damage, both lungs fields, alveoli are damaged. Due to pneumonia, within a window period of 7 days. Or aspiration of gastric contents within the lungs, aspiration pneumonia. So 40% cases pneumonia, around 40 to 40% or 40%, 42% due to sepsis, systemic inflammatory reaction to infections, right? So sepsis from any other organs or due to traumas, multiple fractures, brain injuries, colon surgeries, ultimately traumas, accidents, which cause acute inflammation, systemic inflammatory response, neutrophils get activated and get infiltrated into the lungs, right? So traumas, shock, acute pancreatitis, inhalation of chemical irritants, chlorine, direct damage to the lungs, acute inflammation, oxygen toxicity, a lot of oxygen is given to the damaged lungs, free radical injuries, uremia, drugs, heroin, bleomycin, for example, these are the drugs. So ultimately, all of these causes locally within the lung or systemically other causes. They initiate, then within a 7 days period, the patient is suffering from severe dyspnea and suffers from oxygen refractory respiratory failure, right? Good. So pathogenesis, most of the part we understood that neutrophils get activated. How? Actually activated alveolar macrophages, which are activated due to inflammation. They release interleukin 8. You know interleukin 8 is important factor to activate neutrophils. So now macrophages, the cousins of their inflammatory cells, neutrophils, or you can say their brothers, they release interleukin 8 to activate neutrophils. Now neutrophils will release what? They will release proteases free radicals. So let's say here we draw a picture. So this is an alveolus, type 1 cells for gaseous exchange, type 2 for surfactant production, alveolar cells, right? So, and this is a capillary endothelial cells. So these are the macrophages which release interleukin 8, which activates the circulating neutrophils. Interleukin 8 activates neutrophils. Now neutrophils leave the capillary circulation and get activated, start releasing proteases, enter into the interstitium, further cross it, release the proteases, damage the alveoli, and enter into the alveolus. And here start releasing again what? Proteases and free radicals to cause damage to the alveoli, to cause damage to the capillaries. Ultimately, from capillaries, proteinaceous fluid will leak out and infiltrate the alveolus. These cells will die because of free radicals injury from the neutrophils and protease injury to form this hyaline membrane or orange looking or pinkish looking histopathological finding that is called hyaline membrane. That is the hallmark of the ARDS. So what we understood simply, macrophages release interleukin 8, interleukin 8 activate the neutrophils, neutrophils release proteases, free radicals to cause damage to the alveoli and leakage of the capillaries proteins. Good. So that clarifies very well. Even it is a local lung damage or in response to systemic inflammation from various causes like acute pancreatitis, uremia, multiple fractures, etc. Right? Good. So neutrophils release. So first neutrophils get activated under the influence of macrophages, we understood, right? Macrophages under the influence of interleukin 8, neutrophils get activated. Neutrophils release proteases, free radicals, reactive oxygen species, and cytokines. Cytokines further recruit further inflammatory cells, neutrophils, for example, right? Which result in alveolar epithelial cell damage and capillary damage. So alveolar epithelial cells, both type 1 and type 2 are damaged. Type 1 damaged, gases exchange loss. Type 2 damaged, surfactant is not produced. Surfactant keeps the lungs expanded, decreases the surface tension. Now, since surfactant is not produced, lungs alveoli will collapse, right? Further dyspnea. So capillaries damaged, alveolar epithelial cells damaged, resulting in cellular debris, dead cells, plus plasma leaked proteins from the capillaries. So leaked proteins plus cellular debris, now it is called hyaline membrane within the alveoli, right? That is the hallmark finding of the ARDS. Clear? Good. So this is left side is healthy lung alveolus, but on the right side you can see here is the macrophage, activated macrophage in response to lung infection or systemic inflammation, which release interleukin 8. Interleukin 8 activates the neutrophils. Now neutrophils leave the circulation capillaries, get activated, release different chemical mediators, these dotted proteases, free radical cytokines, which start damaging the capillaries itself, which become leaky to release this bluish color you can see. Protein rich fluid, capillaries are leaky, and these proteases and free radicals have started damaging these epithelial cells of the alveoli, which get damaged. So both get damaged, right? Now ultimately leading to formation of the hyaline membrane, right? So it is quite simple. We understood nicely. Let's go ahead further. Mortality. The overall hospital mortality of ARDS rate is around 40% patients die, right? So now remember what we understood was acute respiratory distress syndrome that happens due to primary lung damage or secondary lung damage from other inflammatory conditions, systemic inflammations, right? So, but now remember there is an other respiratory distress syndrome, other type that happens in the neonates, especially reserved for the newborn babies. That is called neonatal respiratory distress syndrome, also known as hyaline membrane disease. The interesting point here it is that these neonates who suffer from respiratory insufficiency distress immediately after the birth also show bilateral lung damage on the alveolar level, and same histopathological hallmark of hyaline membrane is found. That means cellular hyaline is composed of what we understood, the cellular debris of alveolar epithelial cells and the capillaries leaked plasma proteins, fibrins, etc. Right? Good. But here the patient is neonate. And what the causes are that newborn baby is suffering from severe dyspnea, right? And life-threatening respiratory failure. It is because the newborn has severe respiratory failure due to deficiency of surfactant. Yes, surfactant. Patient is not suffering from pneumonia or inflammatory systemic inflammation, sepsis, multiple fractures. No, it is purely because the cause is here in the patient is newborn, and second, the child is having deficiency of surfactant. Why surfactant was low? The surfactant we understood it is mainly composed of dipalmitoyl lecithin surfactant that is synthesized and released from the type 2 alveolar cells. This surfactant keeps the lungs expanded, decreases the surface tension in the alveoli, so the lungs remain expanded. Since surfactant is not there, so this is the alveolus, the surfactant is produced. If the surfactant is not produced, then this alveolus will be shrunken, smaller. So the child is suffering from severe distress due to lack of expansion, constriction of the alveolus. Further, capillaries cannot exchange the gas, acidosis, and then further neutrophil activation, and same neutrophils will start damaging the alveolar cells, type 1 and type 2. Further worsening of the situation. So child is suffering from same histopathological findings of hyaline membrane formation within the alveoli, but the cause is surfactant deficiency. Why is the surfactant deficient in a newborn? The major on top cause is immature babies, babies who are born before the term, because surfactant is synthesized after 28 weeks of gestation. Then it is boosted up. Surfactant production is boosted up after 34 to 35 weeks of gestation. But if the baby is born at 30 weeks, 32 weeks, then surfactant is not sufficient. So the child is now suffering from respiratory distress syndrome, right? Neonatal respiratory distress syndrome. The other cause can be maternal diabetes. So ultimately, the pathogenesis is same neutrophils, which cause damage to the alveoli and capillaries by releasing proteases and free radicals. But the cause is here surfactant deficiency, right? Good. So now let's interpret this case of acute respiratory distress syndrome. A 55-year-old alcoholic male is hospitalized with severe abdominal pain associated with nausea and vomiting. So, abdominal pain is severe. There is some pathology in the abdomen along with the nausea and vomiting. Laboratory studies show marked elevation of serum amylase and lipase. What do you think? These are indicator of what? Abdominal pain severe, amylase, lipase, pancreas. Yes, exocrine portion of the pancreas. So patient is suffering most likely from pancreatitis. During the hospitalization, his condition deteriorates and he develops severe respiratory distress. Now the lungs are secondarily suffering. On physical examination, there are crackles bilaterally and infiltrates bilaterally on chest X-ray. So bilaterally lungs have infiltrates, inflammatory exudates accumulations, bilaterally both lungs after pancreatitis. The patient fails to respond to mechanical ventilation and 100% oxygen is given but fails because the both alveoli are damaged, filled with exudative protein and cellular debris, and dies soon after because of progressive respiratory insufficiency. Which of the following autopsy findings is most likely in this patient? Is it lung hyperinflation? Are the lungs hyperinflated? Or interalveolar wall destruction? Or is it alveolar hyaline membrane formation? Or intraalveolar hemorrhage? Or cardiomegaly? You know, the correct answer is option C, alveolar hyaline membrane formation in both lungs, right? Very well, we understood what hyaline membrane is. Typical the cases of acute respiratory distress syndrome, which followed after the pancreatitis, right? Neutrophils got activated and started damaging the alveoli. Why we exclude lung hyperinflation? That hyperinflated lungs happens in emphysema case, in which the walls of the alveoli are damaged, destroyed due to loss of elasticity. Intra-alveolar wall destruction, that's also a part, inter-alveolar wall destruction, again part of emphysema. There's no such accumulation of hyaline membrane, and in these upper two causes, the history is chronic. Patient is chronically suffering. But here, in the current case of this 55-year-old, the history is of within 7 days window. Following pancreatitis, acute pancreatitis, now the patient is suffering severe acute respiratory failure, right? So these option A and B are excluded chronic diseases of lungs. The D option, intra-alveolar hemorrhage. Frank hemorrhage happens within the alveoli because of other causes, just like good posture syndrome, vaginal granulomatosis, in which lungs get damaged as a part of the immune response, and there is blood accumulation, right? So there is not like hyaline membrane formation. And E option, so D is excluded. E is cardiomegaly. Cardiomegaly, if a patient is suffering from cardiomegaly, that means congestive heart failure. So it will be also long chronic history of respiratory insufficiency that mostly responds to the diuretics, inotropic agents to increase cardiac output, and patient improves also with oxygen therapy. But in this patient is not responding to even 100% oxygen supplements because the alveoli are damaged. And so this part is also excluded. So ultimately, alveolar hyaline membrane is the hallmark of ARDS in this patient's in autopsy finding, right? These are the book references which I used. I hope the concept clarifies. So if I quickly summarize what we understood, that was actually ARDS, what we understood. It is an acute respiratory failure, bilateral alveoli are damaged with accumulation of exudative protein-rich fluid and cellular debris due to effect from the neutrophils. Why neutrophils got activated? Due to local lung damage, for example, due to pneumonia or systemic inflammations like sepsis, right? So this is all about ARDS. So I hope you understood, you enjoyed the lecture and the practice questions. See you next time. Thank you very much. Have a nice day.